So next I invite Dr. B. Ramesh Babu. His topic is challenges in ICL sizing. I think the most challenging task.
Yeah, good morning. Good morning, everyone. I thank AOS and chair and co-chair for giving me this opportunity. I'll be talking on challenges in ICL sizing. I'll be discussing two cases where I have faced problems. I don't have any financial disclosures. Coming to case 1, 23-year female came for refractive surgery. She had a spectacle power of minus 10 with 0.75 cylinder in the right eye, 9 with 0.75 in the left eye. And we have noted some, otherwise anterior chamber and posterior chambers are, anterior segment, posterior segments are normal. And we have noted few anterior subcapsular opacities in the right eye in the lens. Otherwise, everything in both eyes was normal. Coming to op scan report, it showed palm first keratoconus. And Sarais also confirmed the same thing. Palm first keratoconus. So we decided to go ahead with ICL in this case. We have the habit of using 3 instruments: op scan, Cyrus, and digital caliper. These are the white to whites and anterior chamber depth. So among the all available sizes, we decided to go ahead with 13.2 mm ICL. This was a technique of ICL. First main port is made 3.2 mm. Then a side port. I have a habit of making only one port, and ICL is loaded. Then it's VQX forceps. It's being loaded onto the cartridge. We'll be pulling the cartridge over the ICL, and the lens is now being implanted. First into the sulcus, then into the first behind the iris. Before the iris. Then we'll be tucking the hood plates behind the iris. I have the habit of first irrigating the behind the ICL through the central hole. Then afterwards, I will be putting the aspiration port near to the central hole. This is the surgery. It was done. So this was the sticker. Our next day post-op vision was 6/9, but there was a low vault superiorly, and posterior surface of the ICL is touching anterior capsule of crystalline lens. Subluxated ICL inferior temporarily, so that ICL border is visible, and central hole was covered by iris, and IOP was 16 mm. So this is actually undersized ICL. So we decided to exchange the ICL with a little more size of ICL. That is, we will be implanting 13.7 in this case. This is how it's being done. When we placed the ICL horizontally, it shifted vertically. If you have noticed, first we have brought the ICL about the iris, and one footplate was grasped and pulled out. Entire lens can come out. So this exchange was done comfortably. So then afterwards, everything was normal. Post-operatively, patient was good, doing well. Coming to the case 2, female 21 years. She had refractive refractive error of -9 spherical in the right eye and -0.5 with -1 in the cylinder in the left eye. Otherwise, anterior segment and posterior segments are within normal limits. Coming to the op scan report, it was normal except for -9. The thickness may not be sufficient for laser vision correction. Cyrus also the same thing. So we decided to go with right eye ICL and left eye trans PRK. These are the white to white measurements, anterior chamber depth measurements. Left eye we have done trans PRK. Depending on the readings, we have decided to go ahead with 13.2 mm lens. So anyway, I need not show this implantation video. post-op vision was good. The problem is little increasing the, even with the Dimax, pressure was 20 mm of Hg, and the patient was last to follow up because of pain. Although we are calling, patient was not lifting the phone, and people was horizontally ovaled. When we seen her 3 days, after three days, we have seen high walled superiorly. Iris showed some amount of atrophic patches. Even though patient was on Dimax, pressure was on higher side, 28 mm of mercury. So we thought of rotating the ICL vertically so that size may be sufficient for this one to reduce the vault. It was done. Even then, to the satisfaction, the problem was not resolved. So ultimately, we decided to exchange the video. This is the explantation. Again, we are doing the similar manner. No need to, it's the same thing done. But because there was atrophic patch, people was not reacting optimally, especially in the temporally and superiorly. So we decided to go with the single pass 4-through pupilloplasty even after exchanging the lens. This was this how it's being done. We are following the same Amar Agarwal's technique in the similar manner to get the pupil round and small, to decrease the glare of the patient. 4 thrusts are being made. Then suture is pulled on the both sides to get small people. This is not, we thought this is not sufficient, and more also made to get a satisfactory result. So this was the size. We have undersized the length to 12.6. So estimation of the ideal thing is we need to measure sulcus to sulcus for ICL placement, but we are measuring white to white as a surrogate measure. There is a study by Chen et al., which was published in 2021. There, in the extremes of the white to white, that's 11.08 to 12.5, it becomes unpredictable. That's what they are saying. But in our case, although it's within that range only, we faced problems. One is undersized, one is oversized. So we need to be very careful. We need to aware of this problem. So that concludes my presentation. Any thoughts?
How to overcome it?
Huh?
Like how to overcome this issue?
That is a problem. So ideal way is to measure sulcus to sulcus. We don't have proper instruments to measure sulcus to sulcus. UBM we can measure, but it's not accurate.
But these are unusual cases, right? Where you have a 11.4 and you'll end up putting 13.7 finally.
Yes.
And then you have the second one was 12.
12.1
or 12.2, and you had to downsize it to 13.2. So that's very unusual. So maybe I think maybe a UBM or something.
First case I have done 6 months back, and the second case I have done 1 year back.
I can't think of an explanation why it could happen.
No, one thing is, UBM is, though intuitively it would be the right way to go because the ICL goes into the sulcus. It's exactly, you don't have a specific area from where to measure.
That is the
so,
problem.
same surgeon is asked to measure, they give different variations. And all the sizing of lenses by Star as well as other companies is based upon the white to white measurement rather than the sulcus to sulcus measurement. And you mentioned during your talk that we decided to go. You send the measurements to the company and they tell you the measurement, or you decide?
Sir, we decide. We send the data, sir. We do ourselves also. We send the data.
No, I think it's better to send the data to them and let them decide, because it's not, though white to white is the most important determinant. It is also important that to know that whatever we are saying, it's about 1 millimeter more than the white to white, applies to eyes where the AC depth is between 3 to 3.5 millimeters. When it's less than 3 millimeters, you go one size down, and if it's more than 3.5 millimeters, you go one size up. And
in
also,
both cases, it was 3.1.
okay. No, I'm just saying for completion. And then keratometry as well as lens size also matters. These are the reasons why occasionally, in spite of doing everything right, you get a surprise like this. And I think you did the right thing by exchanging the lens.
Yeah.
But it's extremely rare. I mean, it's not that.
Yeah. So I think sometimes intraoperatively also you can, you can judge that, okay, if the lens is moving around too freely, then you know it's like going to be flat. And if it's, if you're not able to form the AC very well and you realize that there's iris coming to the port, then you know it's going to be, the volt is going to be higher. Though at that time you're not going to explant it and tell the patient, okay, sorry, I didn't put the lens. So then you have this dilemma because
Second case, while tucking the hem, there was a lot of difficulty.
So that happens when it's little on the larger side.
Oversize, yeah.
But then from the measurements that you showed, because OBSCAN is what the company recommends.
Yeah.
The white to white diameter from OBSCAN, and you have that. It's not that we're looking at pentacam versus digital caliper. It's not that, right? So you're looking at an OBSCAN value, which is what they recommend, and there you're going wrong. So I really don't know why that happened.
Yeah.
Might make sense to look at ACD again, whether there was something wrong in that ACD measurement, if there were some discrepancies. UBM, if there's something else that's behind there that's kind of causing the, the difference in the walls, but I really cannot figure out why.
No, very rarely you come across situations like this. But the company nomogram takes care of all this, not just the white to white, but the AC depth as well as the keratometry readings.
So I think the issues that we normally have are if you have, say, a white to white which is 11.6, 11.7 or 12.6, 12.7. So there it could go either
just
way.
Just a 0.1, 0.2.
0.1, 0.2 this way, that way. Then if you take, either you take, say, a 13.2 for a 12.6, that could be flat. And if you take 13.7, that could be a high volt. So that's where you have this dilemma, and then you have a discussion with them, and then you toss a coin and decide, let's go to one.
Yeah. And again, for the sake of completion, limbus itself is not a line, but it's a zone.
Yeah.
And you are supposed to take from mid-limbus to mid-limbus. That's the reason, ideally, you should take in the operating microscope with a speculum in place and seeing that. And so you take the spots in the middle of the gray zone, then you are more accurate. And as Dr. Merle said, even a 0.1 or a 0.2 millimeters will shift your sizing by 0.5 millimeters. So obviously that would make a difference.
So ultimate the message is we can't blindly depend on white to white.
But we don't have an answer to that. That's all that we have right now.
Okay, thank you.